A review on transplant guidelines.
Thank you again, and the format that we decided to have for this session between the two societies was having also some report regarding the EASL guidelines, also for the implementation of the guidelines. So, of course, mine is on liver transplantation, so my job is much easier after these two speeches of Saad and Bunda. And I will talk about the new indication for liver transplantation, and I will mention combined liver transplantation, patient selections and contraindication, expanded donor pool, and organ preservation technique, post-transplant management. Regarding the new indication, we just heard a great presentation on about transplant oncology, so I will skip this part, and I already mentioned about the new indication regarding CLF, and we also heard about severe alcoholic hepatitis. We will also have a session dedicated to autoimmune hepatitis. So I just want to say that the epidemiology of liver transplantation is completely changing after the arrival of the new antiviral treatment for hepatitis C. So we have opened the door to many other indications, for example, the transplant oncology one that we just heard. I wanted to underline this paper that came out from a session during the IELTS a couple of years ago. It's a collaboration between different societies where we analyzed the indication as a combined transplantation, the liver with heart and lung and end stage and kidney, of course. And the main point it was when we have to have a combined transplantation and not a single transplantation, and we finalized saying the presence of clinical significant portal hypertension is the main driver to have the combined transplantation. What about patient selection and contraindication? One of the main issues is about cardiac assessment of these patients. So this is an algorithm that has been suggested in the guidelines. The main issue, of course, is how we can manage and evaluate the coronary imaging. It's important to evaluate coronary imaging in particular in those patients that have some risk to develop cardiovascular complication after transplantation. So what has been suggested in guidelines in those that have, of course, some risk, we have to refer to the cardiology, and then with them in the multidisciplinary evaluation, we have to consider if we want to have an invasive or non-invasive evaluation of the coronary. And if there are not risks, we can start with something that might be less invasive. We are using also the calcium score, the CT scan with calcium score in Italy, and we found out and we published it also that can be a very predictive evaluation in this setting of patients. But of course, all depends for the presence or the absence of risk in that patients. There are, of course, some contraindication, for example, the non-treatable stenosis, the presence of ventricular arrhythmia, the FE less than 40%, and also the valvular disease that are not treatable. What about obesity assessment? We are facing also this new indication. We can, in patients with obesity and compensated cirrhosis and the BMI higher than 30 without clinically significant portal hypertension, the suggestion is to have bariatric surgery that can be considered in places where there is an experience in bariatric surgery liver transplantation. In those patients with obesity and decompensated cirrhosis and a BMI more than 35, bariatric surgery should be considered only at the time of transplantation or thereafter. And then we had yesterday the pleasure of having going to the hospital here, the King Faisal, and we were talking about the sleeve gastrectomy. That is one of the possibilities that should be proposed as the technique of choice in selected patients with obesity, with well-compensated cirrhosis, or in the setting of the transplantation. Another big issue is the renal assessment. As we all know, in the situation of cirrhosis with chronic kidney disease, combined liver-kidney transplantation is recommended in patients who are on dialysis for end-stage liver disease or have the most recent EGFR creatinine clearance value less than 30. Of course, we have already underlined the importance of the clinical significant portal hypertension. Pulmonary pressure assessment, a mean pulmonary arterial pressure higher than 45, despite the use of vasomodulator treatment, should be considered as an absolute contraindication for liver transplantation. We were facing another problem with this issue that we are seeing in the past, maybe where we were not doing a proper evaluation for cardiac evaluation. We were missing some patients, and unfortunately this was a really bad complication after transplantation. So in patients with portopulmonary hypertension in need of transplantation, an adequate hemodynamic response to the treatment is required to proceed to transplant. It should be defined as a mean pulmonary arterial pressure less than 35 and portal vascular resistance less than 5 units, or mean pulmonary arterial pressure between 35 and 45 and portal vascular resistance less than 3. This is something that we have to do at the multidisciplinary level with our people from intensive care unit and the pulmonary specialists. Age. We were talking again yesterday in the hospital about age. In our idea, age per se should not be considered a contraindication for liver transplantation. Is much more important not the age of the patient, but how many years the patients showed. There are patients that are 75 years old, but they seem to be like much younger than this, and there are really decompensated patients with 50 years old that looks like much older than this. So age shouldn't be a contraindication. Of course, in our center, for example, we transplant until 75-year-old. In other center in Italy, they don't transplant after 70 years old. So this is something that needs to be discussed at the multidisciplinary, but in our opinion, age shouldn't be considered a contraindication for transplantation. Of course, another big issue is the presence, because we are transplanting older patients, so the issue is a patient with prior malignancy. Of course, again, we need to analyze from a multidisciplinary assessment and consider the timing of the transplantation. Again, this is not a contraindication, but we need an interval. It depends from the type of the cancer, the malignancy we had before the transplantation, and these are the timing that are suggested for the different malignancy. Of course, there are some malignancies that needs more time before we can consider for transplantation. Frailty assessment hasn't been considered in the past that much, but now it's something that we really need to consider. During the transplant evaluation, all patients with cirrhosis should be assessed for frailty. How can we assess for frailty these patients? From the easiest way, so a CT scan seems to be the best way, and what we have to do is we have to push the patient for some activities of daily, and these are all the other possibilities that we can use for making a proper frailty assessment. Frailty per se should not be a contraindication, and any frail patient should be evaluated for rehabilitation and nutritional support. So we can consider also frail patients, of course, but we need to support them. We need to support them with nutrition. We need to support them helping them for making some exercise. We know that it's not very easy in this setting of patient, but this is something that we can work with the patient as well. What about expanding donor pools and organ preservation technique? As you know, we are now able to use also HIV and HBV positive. I mean, HBV has been used for a long time. Regarding HCV positive patients, the recommendation is to use the RNA positive graft in both RNA positive and negative recipients, and it could be considered after a proper informed consent, appropriate organ quality, and then rapid initiation of effective antiviral therapy are guaranteed. So we need to use these organs only in those patients that can be accessed to the treatment. HBV positive, we've been using these anticore positive donors for a long time in both positive and negative HBsG antigen in patients. Of course, they need to have nukes after the transplantation. But we can also use HBsAg positive donors, even HBsAg negative recipient. The main issue is on donor with HDV and the recipient with HDV. That is something that allocation is not recommended. So we can't use S antigen positive donors in S antigen D and delta positive recipient at all. Of course, this patient needs to go through antiviral prophylaxis with analogs after the transplantation. Now we can also use HIV positive donors. Of course, the use of these donors can be considered in HIV positive recipients if there is an option for effective indefinite anti-HIV therapy and the recipient provide informed consent. So informed consent is very important in this setting. Usually we do in our center a single informed consent where we can provide them with all information, all the possibilities that are showed, that can be offered at the time of transplantation. Also with the CDC and, of course, living donor where there is the possibility. So CDC, these are the independent risk factors in the transplant, in the liver transplant topic, and of course a donor age of higher than 60 years old, a donor warm ischemia more than 30 minutes, graft cold ischemia more than 6 hours, the recipient is with a higher MELD of 25, and the retransplantation. Living donor, these are all the main suggestions that have been done in the guidelines. Of course, this has to be a healthy adult, freely willing to donate, understands the entire process, minimal to no hepatic steatosis. We were discussing yesterday about still the need to have a liver biopsy in the donors. I think we still do have this need for making a liver biopsy in the donor, even we know it can have some complication. Organ preservation, machine perfusion, organ preservation techniques should be considered in particular when using extended criteria and DCD graft. The strategies should be used to increase the donor pool and the organ utilization. These are the perfusion techniques that are utilized. There are the in situ one and the ex situ one. So this is something that is changing again the epidemiology of the donation. We are now transplanting even donors of older than 90 years old, using the machine, and I'm sure that with the use of this machine, and at some point also some with some gene therapy possibility, we will have the possibility to even get even better donors also when the damage is higher than it is now. And finally, the post-transplant management. Of course, regarding the general population, these are all the rules that we always use about the immunosuppression. What I would like to point out is there are some specific population that we need to take in consideration, in particular those that have some risk of kidney injury after transplantation. In those cases, we suggest to use basiliximab as induction and to start using CNI as late as we can, and then regarding those that have some risk of recurrence of cancer after transplantation, we try to minimize CNIs, and we try to use, of course, suggest to use the mTOR inhibitors, because we know that mTOR inhibitors can help in reducing the recurrence of cancer after the transplantation. Alcohol-related liver disease, we already listened by Saad before about the multidisciplinary approach and the routine screening for alcohol biomarkers. We can't forget about after transplantation. We need to take care of this patient not when there is the recurrence of the alcohol after transplantation. We need to follow them up also in the early phase. PBC using of UDCA after, AIH, the long-term use of low-dose corticosteroid in controversial. Of course, we need a double immunosuppressive regimen. And regarding HBV prophylaxis after transplantation, the gold standard is still immunoglobulin with NUCs, but we can consider a short course of immunoglobulins or a monotherapy with NUCs, and in low-risk patients with HBV recurrence. Post-transplant management of muscle, of course, we need to follow them up about by the pathologist. We want to prevent the recurrence of de novo, and the multidisciplinary team is the main issue of this patient as well. So in conclusion, what's new? Progress in surgical techniques and post-transplant care has opened the door to the new candidate groups, including patients with SCLF, severe cholehepatitis, older recipients, and selected oncologic patients. Better selection of transplant candidates with a greater focus on cardiovascular risk assessment. Emerging factors as fragility and sarcopenia are increasingly integrated into candidate selection. Expanding donor pool by broader use of extended criteria donors and by enhancing graft utilization through novel organ strategies. Personalized post-transplant management. We haven't mentioned the AI, artificial intelligence, that would help a lot as well on preventing disease recurrence and tailoring immunosuppressive regimen. Thank you for your attention again.